Nikita? Thank you. Elisa? There you are. Jeffrey? Thank you. Melanie? Hello. And Caitlin. There's Caitlin. All right, so just missing Kylie. Kylie? No? All right. Hopefully she will join us. I will warn you, I'm having some internet issues, so I'm going to turn off my camera for now because it keeps freezing and it wouldn't let me into the meeting. So I'm going to turn off my camera, but I'm going to still be talking, so hopefully that will help with the internet. Not sure what's going on with it. The class schedule is not available. What in the heavens? Let me look. Okay, that's interesting. I will figure out where that went because it was there yesterday. I'm not sure where it went, so let me figure that out. I will get that fixed. I'll make a note. If you have any questions about this schedule, let me know now and I can answer them. I have it printed out so I can answer those questions, but I'll follow up and get that fixed. Yeah, Melanie?
The module roadmap is also not available. It's in the trash.
Okay. That is odd. All right, I'll send a message to the school to see if we can work on that and get it updated. Oh, there you go. There's a message. Working on putting it back, and we'll get it updated and fixed. There we go. Voila. Thank you. So we can recheck those later, make sure that they're back, and if not, they'll be back up hopefully by the end of today. Thank you for letting me know that. Any questions before we get started on chapter 20? No? And Kylie, was that you who just joined us? Yes, there you are. Okay, got you down. Thank you. So we will start out going over chapter 20 where we left off yesterday, and then we'll finish up on the workbook chapters 18 through 20 from yesterday, and then we'll get started on new content. So starting out with chapter 20, we're going to talk about mental health and mental illness. Hopefully, here we go. All right, so the definition of mental health. Mental health is a term that refers to normal functioning of someone's emotional and intellectual abilities. Internet doesn't work and nor does my mouth, apparently. Characteristics of someone who is mentally healthy. They get along with other people, able to adapt to change. They can take care of themselves, take care of other people. They're able to give and accept love, deal with situations that cause anxiety, frustration, or disappointment. They take responsibility for their own decisions, their own actions, and their own feelings. And they're able to appropriately control and fulfill desires and impulses. When someone has a mental health disorder, this disorder affects their ability to function, oftentimes causes behavioral changes like confusion, agitation, disorientation, and anxiety. Kind of depends on what type of mental health disorder for what sorts of symptoms we would see. Important to know that sometimes people have what's called a situation response. A situation response is similar to the things that we would see with a mental health disorder, but a situation response is a temporary. So the symptoms that that present are temporary. They are not going to be a lifelong condition. So, an example of a situation response would be like a midlife crisis, if you've ever heard of that, where basically partway through someone's life, they just all of a sudden have this realization like, oh, I need to do something different. So, usually it's some sort of personal crisis that causes that. There are temporary changes. Um, it can also result from various different medications or a combination of different medications that can cause side effects, which can exhibit a situation response as well. So, a mental health disorder is a chronic condition. A situation response is an acute or temporary situation. So, what sorts of things can contribute to mental health disorders? Stress, especially if that stress is not able to be managed with coping mechanisms. There can be a genetic factor or family influence. Experiences, especially weak family relationships or trauma during childhood. And also physical illness. So, physical illness, disability, aging, chemical imbalances in the brain, as well as additional substances, whether they be legal or illegal. Substance abuse can also worsen the mental health disorder. The term fallacy means a false belief. Important to know that when someone has a mental health disorder, they don't get to choose whether they have it or not. They don't get to choose that one day it's just going to be better. It's very similar to a chronic physical illness, in that someone who has a chronic physical illness can't just choose one day that they don't want to have heart disease anymore, right? It's not a choice. Unfortunately, when someone is diagnosed with something like this, it requires symptom management, just like the physical disorders that we talked about. Also important to know there's a difference between a mental health disorder and an intellectual disability. An intellectual disability is actually a developmental disability that causes below average level of mental functioning. So it is not a type of mental health disorder. So both different types of residents are going to need, obviously, additional assistance and support, and they're going to need care from us just like anyone with a physical ailment or disability. It's important to understand the correlation between physical and mental illness as well. Being mentally healthy can reduce stress and help to decrease the symptoms or prevent some of the physical diseases, as well as the reverse. So, being physically healthy can help to prevent or decrease the likelihood or the severity that someone is going to have a mental health disorder. So, the two go hand in hand. Really important to know that someone who has a mental health disorder, if they experience high levels of stress and symptoms are not well managed, that can negatively impact their physical well being also. So think about in your own life what you do when you get stressed. Is there some sort of technique that you use? Maybe you go for a walk, or maybe you do some sort of hobby that you enjoy. Maybe you get some rest, or you go spend time with family or friends. So think about the things that you do in your own life to help when you are experiencing stress. Know that when we're communicating with someone who has a mental health disorder, we're going to treat them as the appropriate age that they are. Remember, we don't talk to adults like they're children. That's considered abuse. Really important to communicate using simple, clear statements, normal tone of voice. Again, look at body language. You want to be at eye level, so if they're standing, standing next to them. If they're sitting, sitting near them. Make sure that your body language shows that you're engaged, that you're interested. Avoid arguments, same thing we talked about yesterday. Honestly, arguing with any sort of resident or patient is not going to get you anywhere, so just avoid it. Maintain eye contact while you're talking and also listen. Remember to understand. You listen to understand what they're saying instead of just listening so that you can formulate a response. Moving on to different defense mechanisms, which hopefully you were able to get some practice in on your workbook. Defense mechanisms are unconscious behaviors that we have that help us to cope with the stress that we are experiencing. So we'll go through those examples in your workbook, give you a better idea of each of these terms. Important to understand, though, if you are taking care of someone, they don't have to have a mental health disorder to use defense mechanisms. I'm sure if you went through these in your workbook, you could probably relate to some of them, at least one of them, that maybe you have seen used before or that maybe you yourself have used before. Any questions so far? All right. So moving on to different symptoms that we may see with different disorders. So the term anxiety, pretty widely used anymore. Anxiety is an uneasiness or worry about a situation or some sort of condition. So a lot of times people get anxiety before they have a test, or you might get anxiety before you go to the dentist office. That's pretty normal. When somebody has chronic anxiety, so the anxiety doesn't actually have a cause, that is called an anxiety disorder. So GAD, or a generalized anxiety disorder, is typically the diagnosis you would see. A panic disorder, on the other hand, is a disorder where somebody has repeated panic attacks, so heightened episodes of anxiety, or they have constant fear that they're going to have a panic attack. So a panic attack actually has a negative impact on our physical status. It changes our vital signs in addition to causing that episode of anxiety. Some people have anxiety around social situations. So getting into like a large crowd or a large social gathering can cause anxiety. So again, anxiety regarding the situation, which would be some sort of social situation. A phobia is an intense, irrational fear of something. Could be an object, could be a situation, could be a place. For example, claustrophobia, fear of being in an enclosed space, is one of those things. Arachnophobia, fear of spiders. So there are a lot of different phobias. OCD, or obsessive compulsive disorder, is a disorder that is characterized by either repeated intrusive thoughts or repeated acts of behavior that cause the individual stress and anxiety. So when someone has OCD, they may have like a little voice in their head telling them to do something repeatedly. PTSD, or post-traumatic stress disorder, is caused by past trauma. So either experiencing past trauma themselves or witnessing past trauma in the past. So to give you an example of PTSD, when I worked in the locked psych ward in the hospital, we had a sound barrier between us and the outside and also us and the rest of the hospital. And we would have different people come in and stay with us. Not that they were admitted or forced to be there, but people who had PTSD, typically from some sort of war. They would come around New Year's and they would come around 4th of July. And they would stay with us because they couldn't hear the fireworks. So the PTSD that they experienced, they had severe panic, anxiety related to those loud booms. And so since they couldn't hear them from our facility, that helped them to not experience those flashbacks to their experience in the war. So That is one example. Depression, there's a lot of different names for depression: major depressive disorder, clinical depression, or just depression. It is a type of mood disorder, and the symptoms that are experienced by someone who is going through depression are typically apathy, fatigue or feeling really sleepy, feeling sad, irritability, appetite changes, especially appetite loss, as well as many other symptoms like anxiety, which we already talked about. So, when someone experiences apathy, what that means is that they lose interest in activities that they would typically enjoy. So, if you've ever been to the doctor's office and they hand you a form to fill out and it asks you if you have lost interest in any of the activities that you would typically enjoy or your hobbies, that's what it's asking about, is trying to figure out if there's any sign that you may be experiencing depression. Bipolar disorder and schizophrenia oftentimes get confused. So, bipolar disorder and schizophrenia are two individual conditions. Bipolar disorder is a type of disorder that is caused by or causes two different mood swings. So, bipolar, BI meaning two, so two different separate moods that go from one mood to the other mood very quickly. So, it's a swing between periods of deep depression, so sleepiness, not wanting to do anything, that apathy that we talked about, and then periods of extreme activity. We call these manic episodes. So these are episodes where someone may not sleep for 3 days. They may clean their entire house, do all their yard work, clean their car, and still have energy. That would be a manic episode. So someone who has bipolar disorder that is not well controlled goes between these two extremes. Of course, there is medication, there are treatments that can help to control these symptoms. Schizophrenia, on the other hand, is a psychotic disorder. So, what happens when someone has schizophrenia is they have difficulty thinking, communicating, and managing their own emotions. Oftentimes, they have a mixed reality, so they don't have a good understanding of what is real versus what is not, which having difficulty thinking, having difficulty understanding what's real versus what is not, makes it really difficult for them to make appropriate decisions. Used to see a lot of schizophrenic residents come into the locked psych ward in the hospital. We talked about hallucinations and delusions yesterday. Same definitions here. So hallucinations are false or distorted perceptions. Delusions are persistent false beliefs. These are things that are experienced by people who have poorly controlled mental health disorders. So, how are these treated? What are different things that can be done for mental health conditions? Psychotherapy is something that's pretty common. What happens with psychotherapy is it involves the individual, so the resident, and the resident talks about their problems that they're experiencing with a mental health professional. So, talking through the issues that they're going through. Cognitive behavioral therapy goes a little bit deeper. This is a type of psychotherapy. We focus on short term, so things that are happening now and what sorts of skills and solutions that the resident has that they can use to modify those behavior patterns or their negative thinking. Usually, cognitive behavioral therapy is effective for someone who has depression or an anxiety disorder. Other things, medications are most typically what you will see. There are a wide variety of different medications for various different conditions and different behaviors or symptoms that we're seeing. So it kind of depends on what disorder a person has and also what they respond well to, what helps to manage their symptoms. Keep in mind, there's a lot of stigma around mental health disorders. So many times people don't want to tell other people or don't want other people to know that they have a mental health disorder for fear that they will not be accepted or that they won't be understood, or that they'll be put into some sort of category, like, oh, you have a mental health disorder. Keep in mind, it's just like having a physical disorder, right? You don't get to pick. Nobody would pick to have any physical disorder or mental disorder if they could. So important to know that these residents still have the right to participate in their care. They're still a member of their care team. They still have rights, and they still are able to make their own decisions. So caring for someone who has a mental health disorder, report any known changes to the nurse. Be supportive. Remember, listen. A lot of times people just want to talk. They want you to understand what they're experiencing. And remember to always encourage someone to do as much as they can for themselves, right? Having that sense of independence is one of those basic needs that we have. So being able to do something for ourselves can help us to increase our self-esteem, give us a feeling that we have been successful. For someone who has a mental health disorder, it is important to report some different things than we would typically report with physical conditions. We want to still report any mood changes. We would still want to report any physical symptoms that they're experiencing. So if they're excessively sleepy or fatigued, if they have any change in their ability or their desire to do things. So we talked about apathy. If they have any behavioral changes, if they make any comments, whether they be serious or joking, about harming themselves or harming anyone else, those are things to be taken very seriously. If they have any imagined symptoms, so symptoms that they are reporting to you that you can see with your senses are not actually present, as well as if you notice that maybe someone has depression and that depression gets worse when they attend a certain activity or when a certain family member visits. Report those things to the nurse as well, because we want to try to decrease the chances of worsening the mental health disorder with certain activities or visitors or what have you. Any questions so far? All right. Also important to understand, sometimes being under the influence of substances or abusing substances, so using something that is legal or illegal in a way that is potentially harmful to oneself or to other people. There are substances that people can take that can then mimic symptoms of a mental health disorder. So it's important to know if they're actually experiencing a mental health disorder or if there is something related to maybe some sort of substance that has been used. So, signs that someone has used a substance, changes to their mental capacity like forgetfulness or confusion, or maybe changes to their physical appearance, weight loss, changes to the eyes, changes to their personality, irritability, diminished senses, maybe changes to vital signs that we don't have an explanation for. Um, People who are under the influence of substances typically do not function normally. So if you see a change in someone's functioning, that could be a good indication that potentially they're under the influence of a substance. Also, if someone is having repeated issues with other people, family, friends, visitors, other residents, that could be a good indication as well. So any of these changes, we would want to make sure that the nurse is aware. Also, note that substances that are abused can be legal substances or illegal substances. So there are a lot of different substances that, if taken improperly or against the directions on the bottle, can be abused. So I'll give you an example. When I worked in the Lock Psych ward, we had an individual that liked to go into random grocery stores and start drinking cold medication or taking various different pills all down the whole aisle. And then this individual, of course, would get taken into custody, and they would bring her to the facility. So this individual had what's called a personality disorder, so a type of mental health disorder. And the choice that this individual made repeatedly was to try to basically receive some sort of a high off of all of these random medications, which ultimately would result in coming into the hospital, having a place to stay, and friends to talk to, essentially. And of course, having to get their stomach pumped because there was all sorts of weird medication combinations in there. So people can use things in all sorts of different ways. Substance abuse, where we don't usually recognize it, is if a medication is prescribed to one individual and another individual takes that medication. That medication may be safe for use in people, right? It might be a medication that is prescribed for use for something, for example, pain, but a prescription medication is only to be taken by the individual who it is prescribed to. So if somebody takes a prescription medication that was not prescribed for them, they can essentially abuse that medication as well. So there are a lot of things that can be abused. Hopefully, you remember that question from your workbook, which we'll go over here shortly. Also, really important to know your facility's policies as far as different substances go. So, alcohol is a substance. Most facilities will either allow alcohol or not allow alcohol. Some facilities that allow alcohol require any resident who wants to drink alcohol to have an order from the doctor. So they can have, for example, one, 8-ounce glass of alcohol per day, or they might specify what type of alcohol, like hard alcohol, wine, what have you. Really important to follow the policies of your facility, to know where the alcohol is kept, if you are able to serve that alcohol, making sure that you know the process, which typically involves letting the nurse know the resident would be requesting the alcohol, getting the alcohol ready, getting it to the resident, and then monitoring the resident to make sure that that resident is the one drinking it, not somebody else. You don't set it down and someone else comes along and picks it up. So that's usually the process in a facility. Something like an assisted living facility, probably going to be a little bit more lenient. They might serve alcohol with dinner, for example. So know your facility. Remember, regardless of what residents choose, alcohol or not, and regardless of what your beliefs are, we're non-judgmental. We don't make any judgments about whether or not the resident chooses to drink alcohol. Same thing with other substances like smoking, whether that be smoking cigarettes, smoking vape pens, smoking marijuana, what have you. Follow facility policy for that. And whatever that facility's policy is, follow that for the residents. Any questions from mental health or mental health disorders? Nope. All right. Then what we will do next is we will go through workbook chapters. So we'll start out with chapter 18 and progress through those. Let's see if this lovely internet will work. We'll try it. If not, I guess I'll just be a talking blob for the rest of the day. Oh well, right? All right. So starting out with chapter 18 on page 105, section 1. Number 1 is E. Number 2, A. Number 3, B. Number 4, D. Number 5, C. For section 2, under arthritis, multiple choice number 1, B, 2C, 3C, 4A, 5B, 6A, 7D. On the next page, under osteoporosis, numbers 8 and 9 are true, 10 false, 11 true, and 12 false. Under fractures, multiple choice number 13, C, 14A, 15D, 16C, 17C, 18D, 19A, and 20B. Under hip fractures, 21 is true, 22 false, 23 and 24 true, 25 false, 26 true, 27 false, and 28 true. Under multiple choice for 29 through 32, who wants to tell us what they got? Yeah, Kylie?
I got for 29, I got A, 30C, 31B, and 32B.
For 30, what did you have?
C.
That one would be A, so the opposite. So which side should a resident recovering from a hip replacement be dressed on first? That would be the affected side, just because we don't want to move that hip or that leg out of its proper position. So we want to start with the affected side when we're dressing. When we're undressing, start with the unaffected side. And then for 32, I think I heard B, and that one is C. So unable to support any weight if they're non-weight bearing. So no weight at all on either leg. Thank you. And then under knee replacement, for 33, that is true. 34, false. 35 and 36, true. 37, false. Under MD and ALS, number 38 is true. 39, false. 40 and 41, true. And 42, false. For short answer question 43, phantom limb pain is when a resident feels pain in a limb that has been amputated. Remember that that pain is real, should be reported to the nurse, just like we would report any other pain. Under section 3, true or false, number 1 is false. 2 and 3, true. 4, false. On to the next page, number 5, true. 6, false. 7, 8, 9, and 10, true. And 11, false. Under the scenarios, starting with number 12, what is wrong with the way that this nursing assistant is communicating is that she's giving a long and confusing list of options to this resident, and also expecting him to communicate verbally when it very clearly states that he's recovering from a stroke and has difficulty communicating and confusion, not setting him up for success. For number 13, what's wrong with what this nursing assistant said is that she's speaking negatively about the resident and also acting like he's not there, right? She's talking right in front of him. He can still hear her. For number 14, what is being done right? The nursing assistant is using signals to communicate, which makes communication easier for this resident. Also being polite and patient, and giving the resident the ability to make some simple decisions. Under Parkinson's disease, number 15 and number 16 are true. Number 17 and number 18 are false. Under MS, number 19, you could have covering or sheath. Either or works. Number 20, messages. 21, blurred. 22, rest. 23, communicate. And 24, stress. Under head and spinal cord injuries, 25 is true. 26, 27, and 28 are false. 29, 30, and 31 are true. And 32 is false. Under epilepsy, short answer question 33. Epilepsy can be due to an illness, injury, or cause can be completely unknown. Treatment is typically medications. Also, surgery can be done. Under vision impairment, multiple choice 34 is B, 35A, next page 36A, and 37A. Section 4, number 1, consistent measurement at which someone is diagnosed with hypertension, again, diagnosed by the doctor, not by us, would be 130/80 or higher. One thing I want to mention about blood pressure readings is you may see working in a facility, doctors have different interpretations of normal. Some doctors follow recommendations from the American Heart Association. Some follow recommendations from other research. So follow whatever the care plan says for your resident. So if it said in your resident's care plan to report a blood pressure reading over 140/90, for example, then if it was under that, you wouldn't report it to the nurse. If it was over that, you would report it to the nurse. So you may see those specifics. Unfortunately, not everyone can agree on the same normal. For our purposes, for testing and for clinical, all of the values that we have gone over are what you will use. But I just want to warn you of that. I used to work in a primary care office with 8 doctors, and half of them had one belief for normal and half of them had the other. So whenever I was talking to one of their patients or checking their vital signs, I'd have to remember which normal values we're going by. Some of them were 120/80, some of them were 130/80. So it just kind of depends. So keep that in the back of your mind as you are taking care of your residents. For number 2, causes of hypertension, atherosclerosis, kidney disease, or tumors of the adrenal glands, as well as a complication of pregnancy. For number 3, treatment of hypertension is really important because prolonged, uncontrolled hypertension can lead to a stroke, a heart attack, kidney disease, also blindness. Under coronary artery disease, number 4 is false. 5 and 6 are true. 7 false. 8, 9, and 10 are true. 11 false. And 12 true. Who wants to tell us what causes a myocardial infarction for short answer number 13? Yeah, Elisa?
When blood flow is blocked and waste products aren't removed and the muscle dies.
Good. Thank you. So blood flow is blocked, causes death of that part of the heart, and the heart can't function properly. That results in a heart attack. Under congestive heart failure for number 14, medication. Number 15, fluids and bathroom. Keep in mind when someone is receiving a diuretic, they usually get the diuretic in the morning. So they're urinating throughout the day instead of at night so that they don't have to get up at night and use the bathroom multiple times. So typically, if they are receiving that medication, going to the bathroom a lot during the day. For number 16, activity and then bed rest. Number 17, weighed. 18, pillows. And 19, dizziness. Under peripheral vascular disease, number 20 is C, 21 D, and 22A. Section 5, multiple choice number 1 under COPD is A, 2 C, 3 B, 4 A, and 5A. Under the matching questions, number 6 is C, number 7 E, number 8 D, number 9 A, and number 10 B. On to the next page, section 6, under diabetes. Number 1 is A, 2B, 3A, 4B, 5D, 6C, 7D, 8C, 9A, and 10D. Under hyper and hypothyroidism, number 11 is B, and 12 is D. For section 7, number 1 is true, 2 false, 3, 4, 5, and 6 are true, 7 and 8 false, 9 true, 10 false, 11 true. Section 8, under AIDS, numbers 1 and 2 are false, 3 and 4 true, and 5 false. Multiple choice number 6 is C, 7B, 8B. Next page, number 9, C, 10A, 11C, and 12D. Under cancer, should have an X next to number 13, number 16, 18, 20, 21, 24, and 25. Under multiple choice, number 27 is A, 28B, 29B, 30A, 31C, 32B, 33A, and 34D. For section 9, organizations that provide services and support for people who are ill and their families, who wants to tell us what they wrote down? Yeah, Maricela?
I have the Alzheimer's Association, American Cancer Society, and the National Institute of Mental Health.
Good. Anyone else want to give us any others that they wrote down? No? Could also have things like meal or transportation services, support groups, counseling. social services, any of those are fine. That is not an inclusive list. There are lots of them. Any questions from chapter 18? All right. Moving on then to chapter 19, starting on page 117, section 1. Multiple choice 1 is A, 2C, 3B. Section 2, 10 actions that we can take when caring for someone who's confused. Don't leave them alone. Stay calm. Decrease the noise level in the environment. Use a low tone of voice. Speak clearly and slowly. Introduce yourself each time. Remind the resident of who they are, where they are, about what day it is. Simple instructions, so don't give them a whole bunch of information or instructions if they're confused. Not going to work. And don't rush them. For number 2, possible causes of delirium, infection or disease, fluid imbalance, poor nutrition, as well as drugs or alcohol. Section 3, number 1 is true, 2 and 3 false, and 4, and then on the next page 5 are both true. Section 4, true or false, number 1 is true, 2 and 3 false, 4 and 5 true, 6 and 7 false, 8 true, 9 false, 10 and 11 true, and 12 false. For section 5, looking at the scenarios, it's asking you what personal attitudes could help you in each situation. So for number 1, really important to take good care of yourself. Getting enough sleep, getting a nutritious diet, drinking water, taking your breaks and your lunches. For number 2, use the family to your advantage. So maybe work with the daughter. Ask the daughter if she has any ideas of what the resident enjoys doing. For number 3, try to think about what it would feel like if you had to have someone do everything for you that you could no longer do. For number 4, remember not to take it personally. Unfortunately, it's the disease process, it's not the resident. For number 5, work with the symptoms and the behaviors at the current time. Remember, no sense in arguing with someone. We can try to encourage the resident to go on a walk, maybe offer to go with him, see if he wants to go for a walk with us. Section 6, scenario number 1. Anyone want to tell us what they wrote down as an appropriate response to this resident? Any takers? Yeah, Samantha?
I said to smile at her and introduce yourself, look happy and inviting.
Good. A smile goes a long way, right? Sometimes we'd have residents who would not know what they were trying to say, and they would just be sitting there staring at us. I would just smile. And then they smile back and forget, oh, yeah, a smile is lovely. It's comforting. So yes, definitely smile. Introduce yourself. Maybe you can try to orient them. Sometimes that frustrates people, so be careful. If they start to get agitated, just stop. Don't orient them. But sometimes reminding them, like, this is where you are, it's almost breakfast time or it's almost lunchtime. This is what you should be doing right now, can give them a sense of like, oh, okay, I'm in control again. I understand what's going on. So it depends on the individual. Sometimes it upsets them. Sometimes it's comforting. So kind of pay attention to that behavior. For number 2, we want to answer the question with the same words every time. It gets a little repetitive, but ultimately, if we keep answering with different words or different phrases, it's just more confusing. So keep saying the same thing over and over. On the next page, number 3, if this resident is having difficulty remembering a word, you can try to suggest the word if you might think that you know what they're talking about. Same thing. Sometimes that upsets people. Sometimes that's helpful to them. So pay attention to their response. If it upset them, don't suggest the word in the future. Just kind of let them try to figure it out. For number 4, use short words and sentences. Hold up the shoe and say, "Let's put on your shoe." Under multiple choice, number 5 is D. Number 6, A. Number 7, A. Number 8, B. Number 9, B. For section 7, fill in the blank. Number 1, routine. Number 2, consistent. Number 3, self-care and cope. And number 4, mentally. And then for section 8, it's asking whether or not these statements are a good idea for residents who have Alzheimer's or a bad idea. So starting with number 1, that is good. Number 2, bad, not going to be successful. Number 3, good. Number 4, bad. Number 5, good. Number 6, bad. Numbers 7, 8, and 9, all good. Number 10, bad. 11 and 12, good. 13, bad. 14 and 15, good. 16, bad. And 17 and 18, good. Moving on to section 9, it's asking you to say what behavior we have and also what we can do to help deal with that behavior. So for scenario number 1, this resident is experiencing sundowning. What we can do for the sundowning is maybe provide a calming activity. On the next page, number 2, this is violent behavior. We want to step out of the reach of the resident so that we don't get hurt. We also want to report that to the nurse. For number 3, this is agitation. So remove the trigger, turn off the TV, or change the channel. For number 4, this is depression. We want to encourage independence, hopefully help to promote self-esteem. For number 5, this is disruptiveness. We want to try to direct this resident to a more private area. For number 6, this is wandering and also perseverating. So maybe we can go for a walk with the residents, maybe see if one of the residents' basic physical needs need to be met. Try to redirect their attention to another activity. For number 7, this resident is pacing. Reading through this scenario, what this tells me is that if the resident every night, 1 hour before dinner, is pacing, they're hungry, right? Maybe they don't want to wait another hour for dinner. Maybe they're hungry now. So maybe we need to get them a little snack to tide them over, and that will probably stop the behavior. Maybe we can set up with the kitchen to feed this person an hour early every day, or maybe give them a snack between lunch and dinner to help prevent that behavior from occurring for the next, 365 days. For number 8, this is inappropriate sexual behavior. We want to be very matter-of-fact with this resident, let them know that this is not appropriate behavior. For number 9, rummaging, like I said, People with dementia love red things and they love shiny things. So things that we can do to help with rummaging: provide them an appropriate area to rummage, so the rummage drawers we were talking about yesterday. Also, labeling personal belongings with their name and room number. If the resident looks at that name tag and sees that it's not theirs, they may not take it. They may realize, oh, this isn't mine, leave it there and move on. For number 10, that's a delusion. It's a sad one. It happens a lot. It's harmless, so we can ignore it. Maybe we can take this as an opportunity to use reminiscence therapy. Maybe ask them what that place is like, who their wife was, have them tell you a little bit about that. So allow them to reminisce on those good memories that obviously are at the forefront of their mind. For section 10, identifying the therapy that the nursing assistant is using. For number 1, that is reminiscence therapy. For number 2, validation therapy. This one always makes me laugh because my dog's name is Nora. So every time I read that, I'm like, what? Nora? For number 3, that would be activity therapy. Remember, have all of those therapies as tricks in your back pocket in case any of the basic physical needs being met does not actually resolve the behavior or the problem. You can pull those tricks out of your pocket and hopefully engage the resident that way. For section 11, number 1, it's difficult for the family members of residents who have Alzheimer's disease. There's a lot of stress. There's a lot of emotions. It's hard to watch the disease process unfold. It's hard to watch the person deteriorate, forget all of these familiar people and things. It's also a lot of financial stress accompanied with this sort of condition and this sort of care that's required. For number 2, those 2 resources would be financial resources and emotional resources. And then for section 12, resources available for someone who has Alzheimer's disease as well as their family. Us, right, the healthcare professionals. Support groups. I talked about the HOPE group yesterday. Counseling services. And there are also various different books regarding how to cope with a family member who has Alzheimer's, and also various different organizations like the Alzheimer's Association that have great resources available. Any questions on chapter 19? All right. Moving on to chapter 20. Starting on page 125, under section 1, who wants to tell us the definition of mental health? Yeah, Melanie?
It's a term that refers to the normal function of emotional and or intellectual abilities.
Good, thank you. For number 2, characteristics of someone who's mentally healthy. They get along with other people, adapt to change, able to care for themselves and others, able to give and receive love, able to deal with situations that might cause anxiety, disappointment, or frustration, take responsibility for their own feelings, decisions, and actions, and they're able to control and fulfill their desires and impulses appropriately. For section 2, true or false, number 1 and number 2 are true. 3 is false. 4 and 5 true. 6 and 7 false. 8 and 9 true. For section 3, number 1 is true. 2 and 3 are false. 4 and 5 are true. And on the next page, number 6 is false. For section 4, short answer question 1, Mental health is important to physical health and vice versa. Mental health can help to protect and improve physical health, and the reverse is also true. So physical health can help to protect and improve mental health. For section 5, number 1, each individual is different. Personality, likes, dislikes, those all vary between individuals. What works for one person may not always work for another. That's why we have to treat people as individuals. Remember that person-centered care thing we talked about last week? We might need to change the way we're communicating in order to be effective. For number 2, remember adults are not children. We treat each person as we should treat them depending on their age. So we don't treat adults as children because that's considered abusive behavior. It's also disrespectful, demeaning to that person. So very important to treat them as the appropriate age to which they are. For section 6, some practice on defense mechanisms. So number 1 says that Aaron's mother yells at him for breaking a vase in the living room. He goes into his room and yells at his stuffed bear. Who wants to tell us what defense mechanism Aaron is using? Yeah, Jessica?
Displacement?
Good, displacement. So instead of responding to mom, he goes in and yells at a teddy bear. For number 2, when Gia was 10, she was very badly injured in a car accident. She was in the hospital for almost 3 months, but now she tries not to think about that time. That is called repression. Repression is very common for traumatic or painful experiences. For number 3, Macro accuses his little sister Anna of having a crush on the boy who sits next to her in class, and she blushes and cries out, "I do not!" That's denial. She's denying that crush. For number 4, when Esther was 42, her husband died of lung cancer. After his death, she got out the quilt that she slept with as a child and curled up in her bed with it for days. Anyone want to tell us what that's called?
Repression?
Good. So regression, regressing back to something that was comforting in childhood or younger age. For number 5, Wayne is fixing a leaky sink in the bathroom. His wife teases him about taking a long time to fix it, and he replies, "It's not my fault. I can't concentrate on anything with you bothering me all the time." That's called rationalization. So he's trying to come up with a rational reason as to why he can't fix the sink. That one makes me laugh. For number 6, Martin's girlfriend promised to go out with him on Thursday night, but she forgot, and she made plans with her sister instead. Martin is annoyed, but does not say anything to her. When he goes out with his friends that night, he tells them that she is mad at him. So that's projection. He's projecting his anger or frustration or annoyance with the girlfriend and saying that she's the one that's experiencing that. For section 7, multiple choice number 1 is A, number 2, C, number 3, D, 4, C, and 5, B. Under section 8, true or false, number 1 is false, 2 true, 3 false, and 4 true. On the next page, section 9, short answer question 1, observing for changes in the condition or resident abilities, documenting and reporting those observations to the nurse, providing support to the residents, their family and friends, encouraging independence, and being patient, supportive, and positive. Any combination of those is fine. For section 10, number 1 is true and number 2 false. For section 11, multiple choice number 1, you should have circled all of those. All of those can be used or abused. For number 2, that one is C. And number 3 is also C. Any questions from chapter 20? Nope. All right, go ahead and put your workbook away. And we will move on to today's content, starting out with chapter 21. Chapter 21 goes over rehabilitation and restorative care. So things that you may be doing in any sort of facility. If you work in a facility that has a skilled care wing, you would most commonly see rehabilitative care provided in that sort of environment. If my internet starts to go wacky again, I will turn off my camera. But until then, I feel like I'm talking to nobody when I turn off my camera. So I'm like talking and I feel like there's nobody there. So hopefully it will work. All right, so looking at rehabilitation and restorative care. Rehabilitation is care given by specialists, usually like nurse, physical therapist, occupational therapist, etc. The rehabilitation, the purpose of this is to improve functioning following some sort of injury or surgical procedure or illness. So trying to restore someone's functioning back to how it was before. Restorative care is a step that comes after rehabilitation, and that aims to try to maintain someone's functioning, improve their quality of life, and increase their level of independence. So when we look at rehabilitation, if someone has an illness, we're trying to bring them from whatever illness they experienced to a level of better health. If they had some sort of disability, maybe as a result of surgery or an injury, we're trying to bring them up to a level of the ability. So ability to walk, ability to perform range of motion exercises, ability to hopefully be less dependent and more independent in life, whether that be something as large as independence in ambulation or independence in the ability to just brush their teeth. Something that simple can be a lot for someone. So it really depends on what illness or injury or surgery that they have had for how much independence we're going to be able to restore. So helping these residents to hopefully return as close as they can to their baseline or their previous normal is the goal. Sometimes that requires adapting to new limitations. For example, maybe they had a stroke and maybe they have one-sided weakness. Maybe they're not going to be able to return to their previous level of functioning, but maybe we can make some adaptations to their life so that they can still do the things that they enjoy doing. Rehabilitation requires a lot of patience, a lot of encouragement, and a lot of support. You have to focus on small things. Keep in mind someone's not going to go from falling and breaking a hip and having a hip replacement to getting up and walking on their own the next day. It takes time. Also recognize that things that set someone back occur pretty frequently. One of the biggest setbacks in rehabilitation is pain. If pain is not well managed, somebody is not going to be able to be successful in making advancements in their abilities. So for example, if the person is having 10 out of 10 pain in the hip, the chances of them being able to focus on physical therapy, very slim, right? And that's not going to allow them to progress with healing. So being sensitive to different people's needs based on what their illness, injury, surgery was, involving these residents in their care, remember they're a part of the care team, and encouraging as much independence as we can, whether that be something very small or something larger. Symptoms we would want to report to the nurse: an increase or decrease in ability, changes to their motivation, general changes to health, which are any of those things that we have previously talked about, as well as any signs of depression or mood changes. When we look at issues that result from somebody being immobile, we talked about these before. Remember, when someone is immobile, so maybe they had surgery and they're not able to get up and ambulate, or they have some sort of illness, maybe their lungs aren't functioning well, so they can't get up and move around. That results in poor circulation. That results in decreased GI motility, so constipation. That can result in muscle atrophy. That increases their risk of skin breakdown. Also increases their likelihood of an infection, like a urinary tract infection or an upper respiratory infection. So making sure that people are able to be as mobile as possible increases the quality of the skin, decreases the likelihood of pressure injury, increases circulation, so nutrient, oxygen, blood flow and delivery to all of our vital organs, increases our appetite, also therefore increases our GI motility and our ability to eliminate, improves our mood if we're able to just get up and go for a little walk, helps with sleep, relaxation, also increases that muscle strength to help to prevent atrophy. Keep in mind that social involvement in rehabilitation is very important. Participating in activities that can help with that recovery, interacting with residents, sitting down and doing some sort of activity with them, observing their abilities at that time, making sure though to follow the care plan, right? We never want to start some sort of exercise routine or get a resident up and walk them if we don't have an order from the doctor, which is indicated in the care plan. There's lots of different pictures in your book of different devices that can be used to help residents adapt to new limitations. There's a wide variety of different things. It kind of depends on what they're needing assistance with. There are devices that can help them to put their shoes on. There are adaptive devices to help them brush their hair, their teeth, to get their clothing buttoned up. Devices that can help with communication, maybe if someone had a stroke. There are a lot of different things that can be used. So know what your resident is using and know how to use it. Keep in mind if someone has had an illness, injury, some sort of change to their mobility. If they're using a new aid for mobility, a cane, walker, crutches, wheelchair, they oftentimes are off balance or a little bit rusty when it comes to utilizing that device. So stay close by, make sure that you follow the instructions in the care plan for use of the gait belt, how close you should be to the resident if they're ambulating, how far they're able to ambulate. Oftentimes when someone is learning to use a cane or a walker, we might be following behind them with the wheelchair just in case they get dizzy or they're off balance or they get tired or out of breath, and we can just assist them to sit down. So follow those instructions from that resident's care plan. Observing body alignment. So remember we talked about proper alignment, keeping body parts in their natural position, making sure we're repositioning residents, especially keeping this in mind for someone who has had a stroke and maybe doesn't have feeling in part of their body. We need to make sure that those body parts are kept in proper alignment and that pressure is relieved from those body parts, repositioning them as frequently as indicated in the care plan or every 2 hours. Chapter 10 was where we went over repositioning if you wanted to revisit that. Any questions so far? All right. Moving on to prosthetic devices. So we talked about amputations yesterday. Today we'll talk about prosthetics. So prosthetics come in many different shapes, sizes, kind of depends on where the prosthetic is going or what it's doing. Residents who have prosthetics, very important to know that these things are not cheap. These things are fragile. We need to follow the instructions for how to use them, how to apply them, how to care for them, and how to store them. Also keep in mind the resident has the right to choose whether or not they use their prosthetic. If they don't want to wear it, we're not going to force them. For many prosthetics, for example, a leg, there's going to be what's called a stump sock ordered. That stump sock goes on the end of the limb that has been amputated. Between that limb and the prosthetic device, it helps to prevent skin breakdown. We want to make sure to observe the skin before we apply a prosthetic and also after we remove it. Never show any negative feelings about a prosthetic. Remember, non-judgmental. And as far as the prosthetic goes, if you notice it's not in proper working condition, don't try to fix it. Just report that to the nurse, and then the nurse can figure out what needs to be done. One type of prosthetic, not super common, but some people do have artificial eyes, so prosthetic eye. If we're helping to care for someone's artificial eye, we want to make sure that we are washing our hands, following standard precautions, knowing that the artificial eye is coming out of the eye socket, which is bodily fluid. So wearing gloves, making sure that we follow the instructions in the care plan. Most residents who have artificial eyes can care for them on their own. So we may just be assisting them to wash their hands, maybe assisting to get that artificial eye in a cleansing solution, usually like warm water or some sort of specific solution that has been prescribed by the eye doctor. Artificial eyes can be damaged if we use too warm of water, so hot water should not be used. Also, should not soak this in any sort of solution like rubbing alcohol or hydrogen peroxide. That can actually cause the artificial eye to crack. If we're storing the artificial eye, we want to be very careful to line whatever basin or container we're storing it in with a piece of gauze. That way, if it gets dropped in there, it doesn't crack. Also, just like we would for dentures, making sure that that container is labeled with the resident's name and room number. If we're assisting with reinsertion of the artificial eye should be moistened, again, with saline or some sort of warm water. And then in order to get it into place, you want to place it under the upper eyelid. And then if you pull down on the lower eyelid, it will go into place. Moving on to range of motion. So we've been referencing range of motion exercises for the last few days. So what are these things? Range of motion exercises, abbreviated ROM, are exercises that put each joint through its full arc of motion. Range of motion exercises are labeled by who is actually performing the exercise. So if the exercise is being performed by the affected resident without any help, we call that active range of motion, AROM. If the range of motion exercise is being performed by the affected person and the nursing assistant, we refer to this as active assisted range of motion, AAROM. So the way I remember that is if there's two A's, AA, that's me and the resident. So active meaning the resident, assisted meaning us. And then passive range of motion, PROM, would be done by just the nursing assistant alone with no help from the resident. So if you're performing the range of motion exercises, that is PROM, passive range of motion. So the exercises are going to be the same. They're just categorized by who is actually doing the exercise. We'll look at these pictures instead of those definitions. So we'll watch videos to give you an example. You'll also get to practice this in clinical. When we are doing range of motion exercises, we are putting each joint through its full arc of motion. So common motions that you will see for the legs and for the arms: abduction, so removing the limb away from the midline of the body, and then adduction, adding the limb back to the midline of the body. Flexion and extension, those ones should be pretty familiar. Dorsiflexion just means flexion of the foot. Dorsi means foot. Rotation, so rotating that joint space. Pronation and supination should look familiar, right? Because a prone position is face up, supine position is face down. Or sorry, the opposite. Prone position is face down. Supine position is face up. So you can see the hand in a prone position versus in a supine position. And then opposition has to do with the fingers. So touching opposing fingers to one another puts all of the joint spaces in our fingers through their full arc of motion. So again, these different exercises are classified by who is doing the work. So PROM, we are doing all of the work. AROM, resident is doing all of the work. AAROM, us and the resident are both doing the work. So we will watch the different videos in order to get an idea of what this looks like. So these are skills videos number 15 and number 16. So we'll start out with skills video number 15, looking at some passive range of motion. So nursing assistant doing the work.
Hi, Ms. Bragg. My name is Betsy. I'm your nursing assistant today, and we need to do some range of motion on your knee and your ankle. Okay.
Privacy is provided with a curtain, screen, or door.
Privacy.
The client is instructed to inform candidate if pain is experienced during exercise. The leg is supported at the knee and ankle while performing range of motion. The candidate bends the knee and then returns the leg to client's normal position. This is done at least 3 times, supporting the foot and ankle close to the bed while performing range of motion for ankle. The candidate will push and pull the foot toward the head and pushes and pulls the foot down. This is done at least 3 times. A critical step, while supporting the limb, moves joints gently, slowly, and smoothly through the range of motion, discontinuing exercise if client verbalizes pain.
Got your colon. I would wash my hands, and the skill's complete.
All right, so then the upper body, again, passive range of motion.
Privacy is provided with a curtain, screen, or door. The client is instructed to inform candidate if pain is experienced during exercise. The client's upper and lower arm are supported while performing range of motion for shoulder. A critical step, the candidate raises the client's straightened arm from side position upward toward head to ear level and returns arm down to side of body. This is done at least 3 times. The limb is supported and the joint is moved gently, slowly, and smoothly through the range of motion.
About shoulder level. Let me know if there's any pain with it.
A second critical step, the candidate then moves the client's straightened arm away from the side of the body to shoulder level. This is done at least 3 times, all the while the candidate is supporting the limb, moving it gently, slowly, and smoothly through the range of motion unless pain is verbalized. The candidate ensures the signaling device is within reach and the bed is in low position.
Wash my hands, and the skill's complete.
All right. So again, you'll get to practice those in clinical. Any questions on either of those before we go back to the rest of chapter 21? All right. So moving on to deep breathing exercises. Deep breathing exercises do require special training, so make sure if you've never done a deep breathing exercise and you see this indicated in the care plan, that you have the nurse just to make sure that you get some instruction and that you're doing it properly. Deep breathing exercises help the resident to expand their lungs. That expansion clears out any mucus and helps to prevent infection from forming. There is a device that I will show you called an incentive spirometer. And an incentive spirometer looks like this. So this little device here, and they're disposable, so each resident will get their own, and then if they no longer need it, we would dispose of it. They're not to be sterilized and reused or anything like that. So this little device has a handle on it so the resident can hold it. It's got a mouthpiece and a tube, and it also has an indicator of basically pressure, so how much expansion is actually occurring. And then you can see there's a little gauge under, it says air life there, and there are two indicators on that area. Those indicators are adjusted by the doctor, so the doctor decides where those indicators should be. And then when the resident is using this device, the indicator should remain between that level, whatever the doctor has set it at. So typically, like I said, this device is given to someone, maybe if they have a hospitalization or they're in rehabilitation. It could be given to someone whether or not they are recovering from some sort of lung condition. If they're immobile, they're not able to get up and ambulate or move around, this can help to clear out their lungs, get rid of that mucus, and hopefully prevent them from getting some sort of secondary infection like pneumonia or other type of respiratory infection. So if you have never seen or used an incentive spirometer, the incentive spirometer itself is pretty easy to use. It doesn't require any electricity, doesn't need to be plugged in. What we do is we assist the resident to hold the spirometer. So there's that little handle on there. We have them take a deep breath in and let that breath out. We want them to put the mouthpiece into their mouth after they have taken a breath in and a breath out. And then we want them with that mouthpiece in their mouth, so lips secured around the mouthpiece. We want them to breathe in slowly, kind of like they're sucking something out of a straw. Once they breathe in, we want them to hold their breath for 3 seconds and then let that breath out. So the entire process is typically repeated a few times. So again, follow the instructions in the care plan for how many times that the resident needs to repeat that. A very low-tech little device that we can use to help to prevent infection. All right. So a little exercise for you here. We have a resident, Mrs. A. Mrs. A had a stroke 3 weeks ago, and she was left with a complete loss of use of her right hand and her right arm. Unfortunately for her, that is her dominant side. Her care plan includes a goal of rehabilitation by having the therapists on the team teach her to do her ADLs, like dressing herself, probably feeding herself, probably bathing herself, all with her left hand and left arm. What's going to be the role of the nursing assistant in this process? Anyone want to tell us what they think? What are we going to do for Mrs. A? Yeah, Melanie?
You would kind of support her more since it is the dominant side that was affected. Try and encourage her to use the left side, be more comfortable with the left side of her body, and other limitations that she may have that can be addressed as far as not just dressing herself, but also feeding herself, bathing herself, or doing basic care needs,
Good.
anything like that.
Yeah. So encouraging, right? We want to make sure to encourage her to start trying to use her left side. Maybe give her some tips or tricks like, hey, if you're going to be dressing yourself with your left arm, put your right arm, your affected arm, in the clothing first. So giving her those pointers, those tips and tricks, and encouraging that independence. Though she may not realize it, being independent is going to help her to be successful. It's going to help her to have that sense of accomplishment, increase her self-esteem, and help her to heal. So really important that we're positive and encouraging. Also, think about this. If she asks us to do her bath for her, should we? And if we should, why should we? If we should not, why should we not? Any ideas? Yeah, Melanie?
My initial reaction was to say yes, because that's our job as like nursing assistants, to be there for the patient. But since the goal of rehabilitation is to teach her to do ADLs with her left hand and arm, maybe it would be better to be there for her during the bath, perhaps, but also guiding her and giving her, like you said, tips and tricks on doing it herself with her left hand.
Good. Yes, definitely. That's probably all of our first reaction is like, yeah, I'll help you, right? But you have to keep in mind the goals, and the goals are for her to become more independent in using her left side. So we can help her. We can, again, give her some tips and tricks. We can be there to support her, but we really want to encourage her to be able to help herself. So think about other limitations she's going to have, like eating, brushing her teeth, washing her hair, putting on her shoes, tying her shoes. Think about all those different things that we do that require usually our dominant side or both sides. If you haven't done so before, I encourage you the next time you brush your teeth to use your non-dominant hand. I also encourage you to stand close to the sink because it's going to be messy. So do that and just see how it feels. I can tell you the first time that I ever tried that, I remember like the toothbrush completely came out of my mouth and I was like brushing my cheek and I was like, what in the world is happening here? It's kind of a weird experience, but it gives you an idea of what it would feel like if suddenly you couldn't use your dominant hand and you had to do everything with your non-dominant hand. Try feeding yourself with your non-dominant hand. Sometimes that hand-eye coordination is not there with our non-dominant hand. So try those things out. See how they work. See how it might feel if you were in the situation like Mrs. A, for example. Any questions on rehabilitation, restorative care? No? All right. We will go ahead and take our first break and then we will come back and move on to chapter 22. So feel free to turn off your microphone and your camera and I'll see you back in 15. Enjoy your break.